Good morning, everyone. Oh my gosh, this is so exciting.
Good morning, good morning.
Good morning. Welcome to the semi-annual SEOW meeting. Thank you all for joining us. Hi, Dr. Stevens. Hi, Dr. Martin. Hi, Dr. Angelette. How are you guys?
Good morning, Laura. How are you? Look at that. You're looking warm and cozy.
You know, I'm actually not. Full disclosure, I might get a blanket during the meeting to put it over my legs. So it's kind of chilly in here. I don't know why. Just turn up the heat. All right. Well, if you guys are looking for the SEOW meeting, you are in the right spot. We're very excited to have so many people join us this morning. One of our co-facilitators and leaders on the SEOW, Sharon Merriman and I, just put in the chat. Can you please introduce yourself if you have a moment in the chat of your name and if it's your first meeting and maybe the agency that you represent. I think we had about 10 or so, maybe even more new individuals register for the meeting today. Good morning.
Good morning, good morning. We're going to get started here in just 1 minute. There are some folks still entering from the waiting room, so we're just going to give it another minute. Then we're going to jump right in. We've got a jam-packed agenda, so we want to be respectful of folks' time. All right. We've got about 2/3 of folks that have joined. We're going to go ahead and get started. My colleague Dana Holtz will keep admitting people, so we'll keep adding friends as we go along. As Dr. Rapp mentioned, this is the SEOW winter meeting, so you're in the right space. If you were looking possibly for your Zumba class, you're not in the right space, but we welcome you anyway. We are the Center for Drug and Health Studies at the University of Delaware. We want to acknowledge our state partner in this work, the Division of Substance Abuse and Mental Health. I know we have some folks there that have already joined from DSAM, and we welcome their support as we go about today's meeting. As Dr. Rapp mentioned, and as you saw as you joined, the webinar is being recorded and it will be available for your viewing. We'll post it on the website within the next couple of weeks, as well as the slides. All of the slides will be available for you, and we'll post it on the website, and you're able to go back and view any of the SEOW meetings that have been recorded and put on the website. Today's agenda, we'll get through some welcome and introductions and invite new people to introduce themselves. Dr. Rapp will go over some highlights from the SEOWs last year, and we'll overview some new data products. We'll welcome a new data champion to the work group, or acknowledge a new data champion. Jim and I will provide an overview of some available data related to violence, and that's going to lead into a more focused presentation by Daryl Chambers. Then we'll do a breakout room. It's for more rich conversation, and then we'll close out with some network share outs. And we look forward to hearing from all the cool and exciting things that you all are doing. So to start with introductions, my name is MJ Scales. I co-facilitate the SEOW with Dr. Laura Rapp, Sharon Merriman Nye, and other colleagues at the center, including Jim Heiberger, Dr. Brittingham, Rachel Riding, all of those folks. We also are joined by other colleagues from the center, including Dr. Ackerman. Dana Holtz is part of that team as well. Our director, Dr. Vischer, is here. I have to check my list. I'm not sure who else is here. Bill Gratton, who's a great support for the SEOW. Who else am I missing? David Borton, my good friend David Borton, always showing up. Jesse Arnold, another colleague from the center who's doing amazing evaluation work. Rachel Schilling, who's another awesome member of the CDAS team. And I think that's it. Have I missed anyone, Dr. Rapp, from CDAS?
I don't think so.
I don't think
Just
so.
do a blanket.
Sneaking in.
Our
So I might
colleagues
have-
are awesome.
Yes. But what we'd like to do now, we see a lot of familiar faces, but if there are any new members who have yet to introduce themselves either in the chat and they'd like to unmute for a moment and introduce themselves and what agencies they're with, we do that for a couple of minutes. New friends.
Good morning. My name is Jonathan Rhodes. I'm the program manager within DSCYF in the prevention side. It's a pleasure being here. I'm here to learn some new things and new data around, drug abuse. So I'm the SABG, the substance abuse grant program manager. So this indeed will be a great opportunity for me to learn some more data on the things that we're trying to prevent. Thank you.
It's so great to meet you. I know that Daryl, Dana, and Dr. Rapp and I are looking forward to, and Bill also, partnering with you on the block grant. So welcome.
Absolutely. Can't wait for these new adventures.
Anyone else? Welcome. Anyone else?
Hi, good morning. This is JP McCall. Just wanted to share the sentiments of Jonathan, who I will be working with as a program administrator for the substance abuse block grant. We are both new to the unit within the last month and are very excited about working with you guys and the future ahead.
Exciting. Welcome. I know I speak for Daryl and Dana and Dr. Rapp. We're excited to work with you all and learn and grow together. Esther, not new to me, but maybe new to this group. Hello, Esther.
Hi, good morning. It's nice to be with you guys. Just starting out after 4 months in the prevention and advocacy department at the LACC. I have 3 years there, a little bit more, but I'm just learning. I'm so excited to be with you guys and learn a lot. Thank you.
Welcome, welcome. Good to see you.
Welcome.
Hi, I want to introduce myself. I'm Sue Mulhern. I work for the National Alliance on Mental Illness in Delaware. I am the Assistant Director of Advocacy and Education. I've been with NAMI for 2.5 months officially as an employee, but I've been volunteering with them for almost 5 years now. So I'm excited to be part of this group.
Welcome. NAMI's a great partner and great champions in this work. So welcome.
Thank you.
Good morning. May I speak?
Of course, please. Welcome.
Good morning. My name is Carmina Taylor. I actually live in Philadelphia, but I am doing work in Delaware with the Youth Football League on drug and alcohol prevention. And I'm learning about the various systems and organizations in Delaware. It's very different from Pennsylvania, and I'm very excited. I just want to give a shout out to Delaware because I think that, our perception is that you guys are just like this small little thing and you have flat roads, in my opinion, but you're doing excellent work. And I just want to give you kudos to all of you guys that are doing work on the ground. I think in particular, I'm not with an organization, we're a subcontractor of, I forget the name of the state organization that is funding this program, but just being a part of this youth football league and having the opportunity to have impact in shaping these athletes as whole athletes is such a pleasure. And so I'm learning and traveling all around Delaware, learning about it. And I'm just so grateful to be on this call this morning. So I'm committed to Delaware and the work that you're doing.
Well, thank you. Good morning. There's many of us who are not originally from Delaware, and Delaware kind of pulls you in. So be careful. They might not let you back. So welcome.
It's also nice too to learn what Pennsylvania is doing. We have, some stakeholders who are really invested in New Jersey as well, and some other surrounding states. So I love it when we can have partnerships with our neighboring states too, and learn from their experiences and vice versa. So, so it's a lot of strength. So thank you for bringing your knowledge as well.
Carmina, welcome. It's Bill Lynch from Attack Addiction, and I spoke to your football team. Spoke to me because I remember you.
Yay! Listen, don't get it twisted. I love Mr. Keister. Oh my goodness. And I love Carvel and Red Lion. And I'm learning. So thank you for acknowledging that.
Good morning, everybody.
Good morning.
Carmina, I gotta follow that energy. Woo, girl. You are You are just lighting up my morning. I was not able to have coffee this morning, but I had Carmina instead. So all good, all good. But hi, everybody. I'm Erin Mitchell. I am the Executive Director for Trauma Matters Delaware. Whoop, whoop. And I just, like I said, I'm so energized after hearing Carmina and everybody else say where they're from and their organizations that they're representing. So I'm here on behalf of Trauma Matters Delaware. I see some of my awesome board members here. So we are just so thrilled that you guys are prioritizing this great work and can't wait to be a part of it and learn more about it. So thank you very much.
Welcome, welcome. Any other new friends that would like to introduce themselves?
Hi, good morning. I'm Abigail Jones. I'm here on behalf of Holcomb Behavioral Health and Southern Newcastle County Communities Coalition.
Good morning, welcome. I saw Tamsin's email and I forwarded it to Dana. Dana does a lot of work with SN4C and Holcomb, so welcome. Anyone else before we move on and move forward with today's presentations? All right, well, welcome to all new faces, those that unmuted and those that chose to maybe sneak it in the chat. So thank you so much, welcome. And now I'm going to kick it over to Dr. Rapp to talk a little bit about the 4 goals of the SEOW.
Thanks, MJ. So welcome everyone again today. We're so excited to have everyone here. We usually start off our SEOW meetings with reviewing the 4 goals. The SEOW initially started in Delaware back in 2007 from funding through SAMHSA, the federal agency, and then down to DSAM, the Division of Substance Abuse and Mental Health, who continues to invest in the SEOW since then. So thank you, DSAM, for doing that. SAMHSA initially started out with the 4 goals, and the SEOW has continued to align with that federal work. The first goal, as identified by SAMHSA, is to identify, analyze, and share data. As you can see on the infographic in front of you, which encapsulates the work that was done in our last contract year that ended in September. That ended in September of 2021. The SEOW continues to identify, analyze, and share data. In fact, it shared data from over 40 different sources during that year, which was an increase from previous years. So we are consistently looking and trying to gain access to behavioral health related data sources that are at the state level, lower than the state level, so a county or town or a city level, but as well as national data as well. So we can look at comparisons maybe to other states or what's happening nationally. The second goal, which is to create data-guided products that inform prevention planning and policies. This, and I think I said this before, but this really is a sweet spot for the SEOW. I think everyone who's engaged with the SEOW facilitator team really loves this goal, and it's one of the things that we get most excited about. And a lot of this is, how do we take that behavioral health data? How do we take those 40 data sources that I just referenced and transform and translate them into data products that are going to benefit you and that will benefit the decisions that you are making for your programs as well as your policies for your agencies and for your communities. And so what that looks like as part of the SEOW is really creating a plethora of different products that hopefully everyone can connect to. And Misha's going to reference a couple of them. One of the key ones is our large epidemiological report. We just put out the 2021 that MJ is going to talk about. And then there are also some other products we've done in this last year, over 13 infographics plus 3 published articles to try to get data out there through as many avenues as we can so it's accessible to you and the individuals that you work with. The third goal is to train communities in understanding and using data. Again, we not only want to provide data, but we are hoping that the data capacity in Delaware increases. And everyone on this call has some invested interest in data, and in the work that you do, you're including it in grant applications, in presentations, or helping to make decisions. So we also want to provide support to you and to agencies throughout Delaware to make sure that the data that you're using is being used effectively, so you can make the arguments that you need to in order to get the outcomes that you're looking for your programs. What that looked like for this last year was 13 different presentations, 34 completed TA or data requests from SEOW members and beyond. Our fourth goal is building state and local level monitoring systems. This goal is actually accomplished by everyone on this call. This is not something that just the SEOW facilitator team does. This local level monitoring and surveillance system is the work that we all do through coordination of behavioral health related data to share that information, to raise flags when we see trends going in maybe ways that we don't want to see, and to brainstorm solutions to get the information out there. So it's your engagement in this robust setting that allows us to push out data more so people can use that data in their policies and their programming. We currently have about 115 people on the SEOW listserv. This is also an increase from previous years as well. So we're happy to see that in a lot of areas of the SEOW, we're gaining more and more traction into maybe sectors or areas that we didn't have as much traction in previous years. With that said, we do have about 10 new individuals joining today. So that's one of the ways that we hopefully you guys can find interest in the SEOW, value in maintaining your relationship with the SEOW so we can continue on. So that is the 4 goals. I want to thank you all for your work and participation for this previous year of the SEOW, as well as what we're doing in the current year. And Meisha is actually going to talk a little bit about some of the data products that I referenced in goal 2.
Thanks, Dr. Rett.
Back to you, Meisha.
As Dr. Rett mentioned, this year was, I think we really pushed out a lot of new information in partnership with our stakeholders throughout the state, as well as certain, driving initiatives that we felt were really important to share. But as always, we did put out the Delaware epidemiological profile and the corresponding infographic series. Shout out to Sharon Merriman Nye and Rachel Ryden for all of their great work on those 2 products. I have to tell you, selfishly, I enjoy when it comes out because it's a great resource for me throughout the year as I'm doing presentations, or people say to me, hey, MJ, I want to know more. Where can I start? Where's a primer on ACEs, or what's a primer on opioids? And I go, let me send you this chapter. Before we even talk, let me send you this slide deck. Let me send you these infographics. And I think it's a great way for people to engage with the topic. Because it's so robust, because there's so many great elements to it, we will do a focused presentation on the Epi profile and the infographics in a few months. Probably it'll be like a spring surprise. Welcome to spring. Here's your Epi report, but it is already on the website. So if you'd like to check that out, please do so. We also did a infographic on violence, and that was kind of, I think, the impetus for this conversation that we're going to have today. As we dig, we kind of dug into the data, Jim and I, and we said, hey, you know what, we need to talk about this. There's some things in here that are worth exploring more robustly. And then upcoming, we have our team has an article in a special issue of the Disability and Health Journal entitled, "Are You Listening? Parental Protective Factors and Early Onset Drinking Among Students with Disabilities in Delaware." So when that link, when that is becomes available, we'll send that. The Epi report is already posted online, and as I mentioned, it's broken down into chapters. You can read the whole thing in one go if you like, but we also have posted it in chapters that have that focus. And I think for me, great if you want to sit down and read it, but I come back to the chapters a lot because I can dive into it. There's charts and tables, as well as robust, narrative and information, policy and legislation. So I encourage you to check that out on our website. We also have corresponding infographics for that. That's one example, the alcohol use in Delaware and mental health among Delaware youth. It's a snapshot of, the data that's in the chapter and in the complete infographic, or excuse me, complete report, sorry. And here is a screen grab of our violence in Delaware youth data infographic that is available on the website. We kind of looked at violence in a few different ways, and also some of the great work that's happening locally and nationally. Delaware Coalition Against Gun Violence, the Delaware Coalition Against Domestic Violence, and we connected those resources. And now I'm going to turn it back over to Dr. Rapp.
Thanks, MJ. All right, so something we have been doing is taking a few minutes to recognize some of the SEOW partners and all the great work they do as data champions throughout the state of Delaware. And so we want to continue with that tradition. The SEOW, it really wouldn't be very effective if it was just us talking, just the SEOW team talking in a silo with each other. It's really only effective because of all the amazing work that you all do with the data in your programs and in your policy making and in your communities. So we want to take a minute to recognize the data champions that you are. That could be building data collection systems. It could be using and sharing the data. It can be questioning the data, saying, does it really ring true to what you know in your lived experience and what you see in your communities? So the SEOW really wouldn't work if we were just in a vacuum. And because we see that we can only do so much, but you all go out and actually live this work and use this data in your day-to-day or month-to-month lives and advocate for change based on what we're seeing in the data. So we want to recognize an agency today for their work. Drum roll, I'll do it on the table. The Latin American Community Center. We want to recognize you guys today, yes, as data champions. LACC and different individuals at LACC have been engaged with the SEOW for years. You guys have been really great partners with the SEOW. We love how you always take data a step further. So you don't just kind of sit with the data. We see you actively including data in your dissemination material, obviously in grant proposals, in your strategic planning, agency-wide. You guys in your prevention side take it upon yourself to track additional data elements that may be helpful and beneficial for you and the individuals you work with. We really love the extra steps you take. And not only that, but you also look at data consistently through an equity lens to ensure that what we are presenting on in the SEOW and what different entities throughout Delaware collect data on, is that ringing true with your community? And are there ways we can develop better data collection instruments so they speak to the communities that you work with and you advocate for? So we want to just take a moment to recognize your long-standing relationship with the SEOW, how you guys are always willing to cross-pollinate different promotional events at the end of meetings. You provide your information. You guys are always willing to share other individuals' information. And it's really just been a joy to have you guys as data champions for the work that you do and as an ongoing partner with the SEOW. So thank you very much. We appreciate what you do. And thank you for being data champions. Yay.
Thank you so much. That's so sweet and so nice. And it feels great to have that recognition. And I just wish Mayur was here because I know that he's responsible for a big bulk of what you just described. And I'm glad that Esther is here to hear that. And I'm glad that you all are able to meet Esther today. And you'll also be meeting Brenda, who's our other prevention specialist. So we've grown and we're very pleased and happy about that. And I'm very happy that I'm able to share in this joy because it feels great to be part of this team. So thank you. And I love seeing my old CDAS family on here. So hi to everybody. I miss you all. Thank you.
We miss you too, but we're happy you're here. And we'll send the certificate out, to the whole team and disseminate and share as you guys see fit. But we really appreciate all your engagement. So thank you. Okay. So we are now, I'm going to turn it over to my colleagues, MJ and Jim, for the data presentation that Misha referenced earlier.
Thank you, Dr. Rapp. Jim and I are going to, excuse me, provide an overview of some violence prevalence data and some of the impact as defined and analyzed through the school survey. Before we do that, though, I do want to make a couple of acknowledgements or notes. And the first one I want to say is that violence and the discussion of violence obviously can be a very tough topic to dive into. And we're presenting data, but data, equates to people, right? And so violence can be tough for folks to talk about and a tough topic to explore. So I would invite you, as you feel comfortable, to engage with the topic, but if you don't, it's okay to take a pause to take care of yourself and make sure that you're okay before you move forward and engaging in that dialogue. The other acknowledgement I want to make is that we're presenting a very broad overview of violence and violence data, and we're not going to dive into all of the topics, things like gender-based violence or sexual violence or violence, that's targeted towards someone because of their identity. But we do want to acknowledge how important those things are and that they are real and that they do exist, and they impact people's lives on a daily basis. And the third acknowledgement that I want to make before we dive into this is that totals don't always tell the whole story, right? And the experience of violence can vary across groups and gender identity and sexuality and race. And so, we're going to present on totals here today, but I do want to make that acknowledgement that violence is experienced by different people in different ways at different rates. And this is really to open the door for more conversation on this topic. So the first thing that I want to talk about is how violence shows up in leading causes of death. And you'll notice in the blue boxes there, that's unintentional injury. Green boxes are going to be suicide, and the red boxes are homicide. And this is data available from WSCARS or the CDC. We have a link for that we can put in the chat. If you're a data nerd or you're really comfortable with public health data sets, this should be fairly easy to navigate. But if you'd like some TA around that, we can see what support we can provide for you. But as you can see, violence often shows up in the 10 leading causes of death across races, across sexes. And I do want to acknowledge that CDC data, sex is male and female, and doesn't acknowledge the broad spectrum of gender. But this is just kind of a snapshot. If we were to do this same analysis and look at race or look at Hispanic or look at sex as available options by the CDC, we would start to see some of these numbers shift because, as I mentioned, folks are impacted differently by violence. When we take a deeper dive into violence specifically, we see that, this is homicide and suicide more specifically, but we see that firearms obviously are a leading cause or a leading mechanism rather for homicide and suicide in the United States. And so there's opportunities here for public health interventions related to this. And we also see things like, there are other mechanisms included in this data, but if you look at the top 3 across age groups, firearms consistently show up as a mechanism of violence. And lastly, I do want to acknowledge that sexual violence is fairly common. 1 in every 6 women has been the victim of an attempted or completed rape in her lifetime. That sexual violence happens across the age groups. It's more prevalent or happened, more often for younger people, but it does show up across the lifespan. The other acknowledgement I want to make, or limitation of the data, is that these are official data sources, right? And we know that violence can be underreported. Intimate partner violence is regularly underreported. Sexual violence is underreported. And so these numbers may be much higher. And so it's important to acknowledge that it's common and how we can dig deeper and open doors for conversation around violence prevention and support and resources for victims. Jim is going to dive into the Delaware school survey data specifically. But why we picked this topic, or why we wanted to look at this topic for this group, is that, you know, several studies acknowledge this connection between adolescent exposure to violence, whether that is, you know, parental violence or parental abuse, intimate partner violence or teen dating violence, or just exposure to violence in the community, is associated with adolescent and lifetime illicit drug use and or mental distress, and or you know, other self-harm and so on and so forth across the lifespan. So now I want to turn it over to Jim, and he's going to dig in deeper to the Delaware school survey data, as well as looking at some of those relationships in the data. Jim.
Thanks, MJ. Hey, everyone. Using these previous studies that MJ just listed as a guide to our analysis, some of you may know, but the Delaware School Survey is administered to 8th grade and 11th grade, and it produces 2 separate data sets. However, we decided to combine the 8th grade and 11th grade data sets. They ask the same questions, just administered to different grades. Combining this data allowed us to increase our N and the power of our analysis. We now had about 5,000 students in our analysis, and 98% of the students' ages were between 12 and 17. And the studies that we're guiding our analysis, they often look at children ages or adolescents between 12 and 17. So it really allows us to take this data and build off what we know in the literature. In this analysis, we're looking at exposure to violence, and that includes hearing or seeing violence at home, getting hit by an adult who intends to hurt you, getting hit by a teen that intends to hurt you, and knowing someone who is a victim of gun violence, or you yourself being a victim of gun violence. We did a 2-sample t-test, and what it showed is that students in both 8th grade and 11th grade, the exposure to violence was not statistically different, which really gave us confidence in combining this data set. Sorry about that. Another important aspect of this analysis is our new WellBeing Index. We're using Control's self-anchoring scale, which is a 10-point scale that you can see in the middle there that ranks from best possible to worst possible. And students are asked on which step of the ladder would you say you personally feel and stand at this time? And then students are then asked 5 years from now, where do you stand on this ladder? What we then do is take the scores and we combine them into 3 categories: thriving, struggling, and suffering. And if you notice, the thriving and struggling and suffering are slightly different between the present and the future, with the future being more strict on the thriving and a wider struggling area. Now, this scale was first developed in 1965, and there's been countless studies that show that it's an adequate scale for well-being. And just recently, in 2018, the scale was tested for adolescents to see if it's accurate, and it proved to be an incredibly useful tool for measuring and understanding adolescents' psychosocial health. So now with this exposure to violence and this well-being index, we wanted to see how these two are related to each other. So for exposure to violence, these graphs right here show the individual components of the variable exposure to violence. For hearing and seeing violence at home, you'll see that students stay consistent at 10%. Getting hit by an adult who tends to hurt them, again, you see some consistency across years, with 7% in 8th grade, and then that number dropping to 6th grade for both the combined data set and the 11th. Teens getting hit by other teens, you see an increase in 8th grade, and then it lowers in 5th, and then hits 7% when we combined. And hearing or seeing, having someone you know or being a victim of gun violence, this is actually a lifetime variable opposed to a past year variable, which the other ones were. And you see, again, this is in the 20s, which indicates about 1/5 of our student population knows someone who's been a victim of gun violence or themselves have been a victim of gun violence, which in itself is a very important finding and something that we want to highlight right here. It is very impactful to know that these experiences are being met by our Delaware youth. Next, what we did was we aggregated these exposures to violence. So no exposure to violence, you see about 70% of students combined have no exposure to violence, which is very good. 8th grade and 11th grade, then for one exposure to violence is 21% for 8th, 24 for 11th, and 22%. And now two or more exposures to violence stables off at 9% across the student population. Now this 9% looks, it's not as robust, but that because we have such a large student population, this does impact thousands of students or hundreds of students, maybe even thousands. Now using the Control's WellBeing Index and looking at exposure to violence, you see that students who report suffering, 38% of those students experienced 2 or more violence exposures, 26% experienced 1 exposure to violence, while 15% experienced no exposure to violence. And then as we move from suffering to thriving, you see a pattern start to emerge where struggling, the no exposure to violence, that number is a little bit larger. Struggling for the 1 exposure is at 33, and then for 2 or more, it's at 31. The most accurate or the easiest to identify, easiest to interpret is this last scale, where if you look at the thriving, the students who report no exposure to violence are significantly more likely to report thriving, while those who have multiple exposures to violence are looking at only 31%. A statistical test shows that these are different these differences are statistically significant. So this pattern that we see right here is very important for us to identify. And we see this again across exposure to violence and students' self-reported future well-being. A similar pattern emerges. Suffering, for students reported suffering, the smallest percent is going to be those who experience no exposure to violence, while the highest is going to be 2 or more experiences of violence. Struggling follows a similar pattern. And then this last category, thriving, mirrors what we saw on the last slide, with 72% of the thriving population being those who report no exposure to violence. And then that number going down as exposure to violence increases. We also asked students whether or not they feel, if they have feelings of sadness, empty, hopelessness, angry, or anxiousness. And we are going to see that similar pattern where those who experience 2 or more exposures to violence are going to the highest rate, or they're going to report that at the highest rate. And those who have none of those exposures to violence are going to be at the lowest. The other literature has also addressed the connection between adolescent exposure to violence and substance use. The Delaware School Survey, as several people on this meeting know, collects a lot of data about substance use at the past year level and at the past month level. Again, we're going to see similar patterns across all 3 major substances, and that's alcohol use, marijuana use, and prescription misuse. Now, the prescription misuse is defined as any prescription medication, such as painkillers, stimulants, steroids, sleeping pills, tranquilizers, or over-the-counter medicines that are used, such as cough syrups that are used to get high. This pattern that we see right here is then mirrored again when we look at a more granular level at past month use. Again, with students who have those 2 or more experiences of violence, exposures to violence, reporting a significantly higher number of past month alcohol use, marijuana use, and RX misuse. And like that earlier slides, all of these differences are statistically different, or are statistically significant, which indicates to us that this exposure to violence and past does result in increased past month substance use. Now, the directionality of this relationship is always up for debate, but we know that there is a relationship that we need to address among our students. And listed here are the references above. We have, of course, our Delaware School Survey data, which I really much encourage anyone to look at and reach out if you have any questions about that product. And then some of the literature we cited is also here, and it's great literature, and it leads you to many other good studies. If this is an area of interest, I highly recommend going through these. There's so many to read and choose from. These were just some of the ones that jumped out at us. And that is our, what we're seeing when examining Delaware school students and this exposure to violence, which mirrors larger trends and literature about adolescent exposure to violence. So thank you, MJ and the SEOW team, for giving me this opportunity to present our data.
Thank you, Jim. I want to take a couple minutes before we get to the main presentation to see if there were any questions about the data that Jim and I shared today. Well, there will be an opportunity for a breakout session and more robust conversation, but I wanted to see if there were any questions at this time. Yeah, I agree, Sharon. I mean, this is powerful data when we think about, you know, well, that's just the way it is, or in the community, this is normal, or in my home growing up, this is just what happened, right? But we see that it does have this relationship between health outcomes now and health outcomes across the lifespan. Any thoughts, any questions, any comments?
MJ, there is something that I always like pointing out with this type of data, and that is there's all of this research on resiliency factors and ways that we can mediate this relationship between adolescent exposure to violence and subsequent mental health and substance use. However, we also have to remember that a lot of these resiliency factors and programs, they're not a solution to the underlying cause of exposure to violence. They're just the best stopgaps that we can put in. And sometimes I want everyone to realize that, yes, resiliency factors, having a supportive environment, a healthy school, being able to visit school-based wellness centers are great ways to mitigate these exposures, but it's no solution to trying to prevent the initial exposure from happening too. And it's important for us to remember that those two happen in tandem.
Great. That's a great point, Jim. I feel like there's, you know, that indicated population, the violence has already happened. How can we support young people who have had this exposure? But then also the universal strategies that we can promote to support parents, to support families, to support caregivers, to support educators and other young people from preventing violence in the first place. I think Dr. Lynch had a question that might be for you, Jim. Did you look at marijuana and or alcohol being the causes of these violent behaviors?
Hey, Bill, and the data that we collect is cross-sectional, which means we ask students to answer both of these questions at the same time, which doesn't allow us to look at a causal relationship or a temporal ordering of things. We don't know if the alcohol use came before the subsequent violent effect, though some of the literature cited in these references does show that sometimes it's a two-way street, that initial violence can lead to subsequent alcohol use that can then lead to subsequent violence, which goes along with some of this literature on victim to survivor to offender, depending on the coping strategies. But the temporal ordering of our data isn't there because of the way the data is collected.
Thank you for that, Jim.
Well,
yes.
I'll just add one quick thought. One of the things that I appreciate about the data presentation, so thank you both for putting it together so thoughtfully, is the relationship aspect. I know you mentioned not causation, but we can see the relationship. And I think that speaks to the SEOW network. We all have individual programs that are focusing on specific outcomes. Maybe that's because of a funding mechanism, maybe that's because of a priority in your community. But the power of data findings like this is showing the relationship between different things, and that if we're all working and collaborating across programs and sharing knowledge across programs, it can lead us to those same long-term health outcomes that I think at the end of the day, we're all interested in for our youth, for our communities, and for our state. So we may all be looking at it from a different angle. Gun violence, exposure to violence, intimate partner violence, substance use, mental health, but some of those long-term outcomes that we're all hoping to see can sort of drive us there together if we continue to look at the relationships between these different components of individuals' lives, which show themselves in the data, which is what Jim and Nisha presented. So thank you guys for doing that, taking the time to do that.
Thanks, Dr. Rapp. I encouraged by the fact that so many people on this meeting or call today are already part of a coalition, are already doing collective impact, because they recognize, lots of folks got to be at the table. No one individual has all of the solutions. If we did, we'd be making millions. No, it really is a collaborative group effort in partnership with the folks who are impacted by violence. And speaking of partnership and collaboration, I do want to introduce our main presenter today, Daryl Chambers. He is a research associate at the Center for Drug and Health Studies at the University of Delaware. He's the executive director for the Center for Structural Equity. He is a champion of this work. He is a scholar and overall an extremely passionate and intelligent individual. And I'm really excited to hear this presentation and to have it kind of launch further dialogue and conversation. Daryl?
Well, MJ, thank you, MJ. Are you gonna be doing the slides for me, MJ?
Whatever you want, sir.
Yes. Well, first of all, thank everyone for coming here. As folks know, the city of Wilmington, like other cities across the country, has experienced an increase in violence, shooting incidents. I know there are different forms of violence since the advent of COVID. So since COVID came along, there's been a lot of increases in shooting, and people are wondering, is it really because of COVID, or it becomes because of gang violence, it because of access to guns? And what I argue that it's a combination of all of them factors. But what I really argue, and people who know my history is know that I was born and I was birthed in a methodology called Participatory Action Research, PAR, right, by Dr. Yasser Payne. And what we simply argue is this. We argue that if you go anywhere in America, not just Wilmington, if you go down in Dover, if you go in Pittsburgh, Buffalo, and if you find what we call structural inequities as a result of programs, practices, or policies, then you're going to find poor health outcomes. So what do I mean by structural inequities? If you find an underperforming school system, here in Wilmington, at one time, it was reported that children who was tested in 3rd grade, that only 12% of these kids was reading, writing at proficiency. It was also noted that the majority of people that's coming out of prison, over the aggressive criminal justice system, was coming to the 19801, 19802, 19805 zip code, which makes up the majority of Wilmington. But they also argue that if you have unemployment or underemployment, or a lack of access to employment, in our first street part project, we found that, and we looked at the age between 18 and 35, men and women, approximately 60% of these men and women who were surveyed were unemployed. But approximately 55% of these same groups were actually actively looking for jobs. So it's just access to jobs too. And what we're going to do with it, as we go through this presentation, we're going to look at the current state in Wilmington. As it relates to shooting incidents, we're going to look at some trend data. Also, we're going to ask a little questions about age, and we're going to look at locations. First, we're going to look at it through bars and graphs. but then we're going to look at it from a more GIS perspective, just so that we can get a picture of actually of what's going on. MJ, the next slide.
Yes, sir. Uh-oh. There we go.
So as I mentioned before, there was a record number of homicides in Wilmington this year. And interesting enough, this article right here, well, this little piece right here came out of an article that was written in the news journal that was highlighting the city council voting no confidence in the police chief. What was striking to me was that the 41 homicides that occurred in 2021, that if we were the same size of Chicago, we would have twice as many homicides as Chicago currently have, or we're 1.5 times more than that of Philadelphia. And this is very striking to me because as I look through the numbers, because I'm part of a group that actually goes out every before 24 hours and visits the family of these shooting victims. So this stuff right here is really personal to me. But what it strikes to me is that in a city, in a town as small as Wilmington, to have this many homicides, to have a no confidence voting in the police chief, and yet the programs that is used to address these kind of incidents are funded to fail. There's my little soapbox. So I always got to go there before I really get into the data. But what I really want to note is that Wilmington is about 70,000 people in a state of roughly 1 million, which equates to about 7% of the population. Yet Wilmington is responsible for approximately 50% of the homicides and over 50% of the shootings. Now I'm gonna sit there and let you pause on that for a minute. 7% of the state total population is responsible for approximately 50% of the shootings and 50% of the homicides. And as we go later on and we look at location and we look at hotspots and zones, you will see that it's even more concentrated than that. And the one thing I want to note is this, is that they have zip codes in Delaware that's bigger than Wilmington. For example, 19720 have approximately 73,000 people in it. And when we look at this right here, people, like I said before, there's a lot of reason why people are trying to find out what is really causing a lot of this violence. But I said before, my argument is really based in the structural conditions, the poor applications of program policies and practice. Before I go to the next slide, let me ask you guys a question. In the data that I collect, I break the shooting incidents down, the victim shooting incidents down into age cohorts. 12 and under, 13 to 17, 18 to 25, and 26 and over. Real quick, y'all, couple in the chat. Which group over the last 11 years would you think will have the most shooting incidents?
Daryl, we're seeing 26 and over. We're seeing 13 to 17 teens, 13 to 17 teens, more 13 to 17, 25 to 34, 13 to 17, then 18 to 25, a lot of teens, a lot of young adults.
Okay, well, thank you guys for answering that right there. MJ, next slide.
There we go.
So before, I'm gonna let y'all stew on that for a minute before I go into the answer to that question, but keep in mind the answer is coming. But first, I just wanted to see that you see like what the trends have been over the last 11 years. And on average, we had about 135 shooting, 115 shooting incidents per year on average. So you can see that right there represent a almost a 10% increase last year, 2021. We have about 135 victims on average, and we have about 25 homicides per year on average through the last 11 years. You know, so we really like, and you see that dip right there. That right there was the first full year that Chief Tracy came on board. and he went out to the community public safety meeting and was actually honored by Trump. And it was a big fanfare about all the work he has done. And I told Chief Tracy at a meeting, because of the small N in the number of homicides, because they'll run around talking about how there was a 63% increase. I said, but next year, if it goes up only 8, do you know it's a 50% increase in that the average, the trend says that we will get about 25, which means that the this anomaly that we have of going down is not really the average. And to take success and say that now we have succeeded and there's no more need to address violence, it's going to come back to bite you in about 3 or 4 years. And here we are now 3 or 4 years later, and we have a record number of homicides. Next slide, MJ. So here was the answer to your question. And surprising to most people, the group with the highest shooting incidents is actually those who are 26 and over. And even when you look at the trends over from January 1st, 2021 to December 31st, 2021, you see has been pretty consistent with the groups who have had the most shooting incidents. And as you look at this, you say that because a lot of the focus with the groups that's currently doing a lot of intervention work is really on intervention. And I seen where Sharon put in there prevention, prevention, prevention. But when you really go back and you look at the CDC report, you see that a lot of these kids, JP, were actually part of the kids department or YRS, and we could have gotten a hold of these kids a little earlier. So while there's been a focus to look at a lot of the intervention stuff, a lot of groups that I'm working with now are really trying to get on the front end of these things right here. But the point I really want to highlight here is that contrary to what you might read inside the newspaper, the group with the highest shooting incident is actually those who are 26 and over. And keep in mind, these are the victims. The perpetrators, there's very little data about them because we only have between a 15 to 25% arrest rate over the last 11 years. And I think that the chief just reported that there is a 60% homicide completion rate for 2021, which is historically high because it's been as low as 25 to 30% in the past. Next slide, MJ. So location. So with the data that we work with, we really want to, because we're trying to say, how can we use this data to inform us where these shootings are taking place? And we're going to dive a little deeper. I'm going to tell you like the zones itself and where these zones are located. But I just want you to see that we have having a lot of trouble. A lot of majority of shootings are happening in what they call the north side. So for people who know Wilmington, this is the Brandywine River going north from Riverside, which is 495, all the way up to Vanderbilt. And it's interesting to note that Riverside is composed of 19802, which is the majority of folks from there are Black and brown people, upwards to like 88%. The next slide, MJ. So these are our zones, right? So zone 1 runs from Jackson Street all the way up to, I think, Van Bruin. I mean, not all the way up to what's that? DuPont Street, from 7th Street down to Chestnut. So that right there is zone 1. Zone 2 runs from Tatnall Street down to Adams Street, from 3rd Street to 10th Street. And zone 3 is the east side of the city. It runs from Church Street to Walnut Street, from 4th Street to 10th Street. And like I said, zone 4 is everything from over by Vander Avenue, north of the Brandywine, down to 30th Street, from Northeast Boulevard or Governor Prince, all the way up to Van Bruin Street. Next slide, MJ. What we found out was that a lot of the shootings that are happening is not happening all across those zones. So my colleague, a scientist down at the Center for Drug and Health Studies, Dr. O'Connell, we were asked by a task force to pull out a map of Wilmington and circle where you think the hot spots are. If I was going to tell you that there was a shooting in zone 1, where would it likely be? So Dan and I got our pencil out and we drew some lines around the zones, and very before we even put the shooting data in. And then we did it for zone 1. Next slide, MJ. We did it for zone 2. Like I said, this right here is, no, go back one. The 3.
My apologies. One moment, sir.
So zone 2, and this right here is the area I said is west of downtown, but east of 95. And you can see that a lot of these hotspots are clustered around certain areas. Next slide, MJ. And the same thing down here in zone 3, which is the Lower East Side. A lot of stuff's happening with a 3-block radius from Bennett Street to Pine between 7th and 10th Street. Next one, MJ. And as you can see, even though the north side is twice as big as the other zones, the incidents are occurring only in a very few places. So what we wanted to do was see, like, okay, well, now let's add the data. Let's add the number of shootings. Next slide, MJ. And let's see where it's at. And as you can see to the right of your screen, that right there is the north side. And if we were able to look at these maps simultaneously, you will see that Dan and I would really are right on to where a lot of these shootings are occurring, right? Predominantly poor Black and brown neighborhoods. And down there on the Lower East Side, that's more in the middle of the picture. That is to the south of the Brandywine. MJ, can you move your pointer up? To the Brandywine River. Right there. That's the east side right there. And to the left of the east side is the zone 2, which is the west side. So a lot of these shootings are happening in the same spots. When you're talking about poor health outcomes, you gotta ask yourself, what impact is it having on the people who live in these areas right here? The next slide, MJ. The next one, MJ. So keep in mind, my argument is this, is that structural inequality leads to poor health outcomes. And like I said before, I'm arguing that if there's an underperforming school, over aggressive criminal justice system, a lack of health care, unemployment, underemployment, opioid crisis, mental health crisis, and if you find these factors compounded anywhere, you're going to have poor health outcomes. You're going to have violence. And not just the violence that we're talking about now, you're also going to have teen dating violence. You're going to have sexual assaults. You're going to have child abuse, so forth, so on. And one of the things I want to look at was how are these things happening, all these shootings happening in certain areas, and what are some common things that's going on in these areas? And the first thing we looked at was housing, the availability of affordable housing. And what you can see here in dark represents a lot of vacant houses, is that you see around a lot of these shootings, there's a lot of vacant houses. Anybody familiar with Wilmington knows that throughout the city, there's a lot of vacant and abandoned houses. So that's one of the structural conditions, because when I asked a representative from the city council, what are the 6 priority things that you think about when you think about the city of Wilmington that needs to be addressed? And the first thing that person said was housing, education, the opioid crisis, mental health, employment, underemployment, overemployment, and gun violence. Next slide, MJ. And the next one was per capita income, right? So how much money are they making? And now Black is, dark colors are not good. So the lack of job, affordable housing, all these things compound, and you see, now you see the overlaps of the shootings. The next one, MJ. And the third one was percentage of unemployment. These right here happen around a lot of places where there's high unemployment. And one of the things that the group that I'm working with is like, how can we address this? So while our argument is that it's structural inequality that's leading to violence, the answer is what? How do we provide quality opportunities to these folks to offset, as Jim said, some of these experiences? So how do we get people back on track? And one of the things that we did, that we became part of a coalition, as MJ was talking about, with the 4 major groups that is actually working now to address some of the violence. And the first group that I will talk about is GVI. GVI stands for Group Violent Intervention. It's more of a criminal justice approach. It does what they call focused deterrence. And for the criminologists in the room, you notice right here means that we're going to lock you up with certainty. We're going to prosecute you fast, and we're going to sentence you severely. So that right there is the criminal justice approach, and that right there is mainly implemented by the state and the city of Wilmington. And the second approach that we got to address some of this violence right here is what they call the HVIP, the Hospital Violent Intervention Programs, where they not only look at people who have been shot, but any kind of penetrating wound, provide wraparound services, a lot of red tape with that right there because of the rules and restrictions of HIPAA. And the last one is, or the third one is the Group Violence Intervention Program. Quick moment, y'all. Out of all these programs, which one you think is funded for success? GVI, which is the Group Violence Intervention Program ran by the state. The HVIP, which is ran by Christiana Care. The community violence-based stuff, which is a group of grassroots local organizations trying to address the violence. The only one out of that group right there is funded to fail is the community violence prevention programs. The only ones. All the rest of them are funded for success, funded to succeed. So now we're going through this phase where we're trying to make sure that those people who have the sweat equity, the social capital, and the lived experience to become part of an apparatus or a team that is addressing the issues. Because while we recognize that is the structural conditions that actually leading to the poor health outcomes, we got to have people from the community to buy into this process. The next slide, MJ. The one thing I want to report out, because MJ, I know you're planning on sending this stuff out, is that in the News Journal article, they reported 41 homicides. But if you look at the data that I collected, it says 39. And the discrepancy comes from when there is a police-involved shooting, certain databases don't count it as homicides, while others do. And I just want to make that right there clear, because I know that some people go back through the data and they look at it and say, CDAS made a huge mistake or Daryl made a huge mistake. So I just want to make sure that right there was clear to the folks looking at the data. The other thing that I will point out is that I collect data from the shootings and the homicides. And if you need access to this right here, just let me know. I got maybe between 15 and 16 variables expanding, looking at different shooting incidents for the past like 12 years. Everybody's welcome to that data right there. And I'll end with this right here, is that the majority of shooting that is happening in Wilmington, what we call acquaintance shootings. It's not random shootings. So I often tell my colleagues, my Caucasian colleagues down at the University of Delaware, you're actually in more danger in or likely to occur violence down in Newark than you are in Wilmington. So I want to dispel the myth that the entire Wilmington is a place where they just go around randomly shooting people. No, this right here is acquaintance violence. As some, it's group violence. And my thing is that don't this right here hamper you from visiting the beautiful city of Wilmington.
First of all, thank you, Chambers. I want to invite folks to let that marinate for a second. you know, if you didn't want to wake up today or be challenged today, this was the wrong presentation to listen to. You know, I always appreciate how much, you know, Chambers unpacks things. Thankfully, we didn't get into any, you know, Marx or Kant today because my coffee really isn't hitting yet, but I knew that was coming. I want to acknowledge, you know, some of the data caveats that exist at the national level too, right? You know, to Daryl's point, when you look at that CDC data, when they talk about the mechanism, one of the mechanisms is legal intervention, and that doesn't count in the homicide and in the suicide bucket. It counts as legal intervention, whatever that means. So, well, you know what that means. But I want to once again thank Daryl for a powerful presentation and invite questions, comments, thoughts to help, you know, unpack this a little bit more. One question I want to lead with is Daryl, I know that you are doing or leading a lot of interventions throughout the community from different directions. What impact have you seen with Stop the Bleed in terms of community awareness around gun violence and also reductions in deaths as opposed to wounding?
Well, let me take you back. When we first started this work, we were working really closely with Christiana Care, and they had a great trauma surgeon named Sandra Minadilla who came to me one day, and as y'all know that I lost a child to gun violence in the city of Wilmington. And I was telling her about what happened to him and how there is no Trauma One Center in Wilmington. And like I said, even though 50% or more of the shootings happen and homicides happen in Wilmington, there's no Trauma One Center in Wilmington. And for a long time, if a person was shot in Wilmington, instead of going to the Wilmington campus or to St. Francis, a child or a person had to actually go all the way down to Newark. And a lot of our kids were bleeding out. And Sandra Medilla said, well, Daryl, after the Sandy Hook shooting, a team of doctors came in, and what they found out was that if someone would apply a little pressure on some of those kids' wounds or stuff their wounds, a lot of those kids could have survived. So they started this program called Stop the Bleed. And it's something that we have been going around the city of Wilmington, what we call initial responders, those who are on the scene, teaching them about how important this kind of work is. And to tell you about how, and you said don't make no Marx comment, but here you go. When you read Marx, the one thing a lot of scholars say is that Marx underestimated the power of the state to step in. And what happened here is that when we wanted to get the city involved in this program, folks who were in leadership at the time said, what does it say about a city that needs a program like Stop the Bleed, right? And what happened is that while we wanted to train them first, an incident occurred where a guy was on a trash truck. He put an oxygen tank inside the trash compactor, and it blew his stomach open. And nobody on the scene knew what to do. And someone who had took our training came by and actually stuffed his wound and held him until the people came. Now, did it save his life? Probably so, right? But my thing is that it goes to the fact that sometimes it's more about protecting your image than actually doing what's right. And I got a great friend called Dr. Henry Smith, who's my mentor and everything. He said this to me. He says, Daryl, never abort the mission, change the rules. You see what I'm saying? And that's it right there. And that's where we're at now. We're saying that we're not going to abort our mission. We're going to change the rule. So if you don't like the fact that this right here makes our city bed, we still have to go out there and train folks in the city in the Stop the Bleed movement. And another incident happened when 4 or 5 people got shot down on 10th and Pine, and a person who had got Stop the Bleed applied the tourniquet to a person's leg. Now, I don't think that the person probably would have died because it was just a scrape on the leg, but the fact that this person went into action, actually recorded it, shows that we are making inroads and progress and addressing some of this stuff, and the people are hearing to the message.
That Stop the Bleed training is powerful. I mean, it resonated with me. I even watch TV shows, and when I see people jump in, I go, no, that's not how you do it, because Stop the Bleed taught me that's not how you do it. A question from Dr. Lynch, any thoughts about incorporating programs similar to those being employed in Camden, New Jersey and Chester, PA with communities and law enforcement that are working with decreasing crime, shootings, and homicide rates?
I remember when Camden first started their Cure Violence program, we went there and trained them. And it was the, because they're looking at the whole shooting as the health epidemic also. I was just talking to some folks from Chester. We have a law enforcement apparatus here that is working with social workers, community folks, and that is GVI. So we don't have a formal MOU where we work together, but there is people who work on the social service sides, like John Cook, Ron Handy, who I work closely with. Keep in mind, the people who are employed with the community violence-based stuff, these are people who are trusted in the community. And like it or not, there's still a lot of distrust in our community with law enforcement. So that right there is something that we got to take in consideration when you ask, are you working with them? Now, there's no formal working with them right there. And even when I'm talking to the police chief, he recognized that there is only a one-way conversation, where the police chief is telling me stuff that's going on, not the other way around, where I'm telling the police chief about what's going on inside the community. So we are working with them, and we are trying to decrease the crimes and the shooting rates. We are in conversations. A lot of those folks who are from Camden and Chester do attend what they call HAVI. So HAVI is the flagship organization that leads the hospital violence and prevention work. So I would say yes to that right there. But as I said, though, you can only get so much done when you're funded to fail. Meaning that they give you just enough money to where next year you come back in September on hands and knees, begging for forgiveness and begging for funds. You can't work like that, because in order to get the best people possible, they have to be full-time employees with benefits with a multi-year contract. It's hard to get. There's one guy right now who is the leading gang expert in the city of Wilmington. We can't take, he got 5 children. We can't take him away from that job right there with only a 1-year guarantee. Because we just got healthcare, Gwen, for our folks. That's Dr. Angelette, that's my other mentor. We just got healthcare for our group. So it's really hard to recruit the people that you need when there are limited resources to bring the right on. Because when they went and got Chief Tracy, they actually went to city council and asked for a raise. So when I go ask and I want somebody, I need you to go to city council and ask for some funds and get them a raise too. So I hope I answered that question. I know it's a long-winded question.
We have about 2 more minutes before we move over to the breakout rooms. Were there any other questions for Daryl?
MJ, this is Gwen. I don't have a question, but I would like Daryl just to talk a little bit about what we've been working on for the last, 7 months, a comprehensive community violence prevention initiative, and how we've been trying to get support for that.
Yeah, working with the GBA consultants, along with the Women's Community Advisory Council, we have put together a comprehensive plan, a 3 to 5 year plan. And in this plan right here, for those JP, here's one for you, JP, IOM, you're gonna be hearing a lot about it. The Institution of Medicine model was saying that we break people down to 3 groups, the universal, the selective, and the indicated. And we have set up a proposal that is going to look at all 3 groups simultaneously. Because what we found out was that a lot of the work and efforts have been really dedicated to what we call the indicated group, right? So those are most likely to be involved in crime already. And a lot of the work has also been geared toward what they call the universal group. These are kids that are left alone, most likely they won't even get into trouble. But the neglected group has been that selective group. So because of shortage of funds, Gwen, and because we have not been able to muster up enough support to get the whole model covered for multi-years, now we've been forced to scale it down. And we said that the group that we're going to target is the selected group. And keep in mind now, with this effort, we have the people on the ground, because we had a community meeting, which about 75 people showed up, Gwen, or more?
About that, yeah.
75 people showed up or more. We also had a meeting with legislators. We had meeting with religious organizations. So there's a lot of buy-in from the community. And what I always argue is this: when I first started this work, I really believed that it was all about grandmom and grandpa. And Gwen heard this 1,000 times, where we just go out there, shake hands, hug people, and everything's going to be all right. And then when I've talked to Dr. Payne, I realized that no, we got to have some science, Jim. We got to have the literature. We got to have the scholarly journals directing us to what we should be doing. But then I also realized that talking to our esteemed Congressperson, Lisa Blunt Rochester, that we also need champions of this work. And we need policy, right? So there got to be a policy aspect to it. So we went out there with that in mind, that, you know what, we actually have to make sure that all these different groups are at the table. So we wanted the people who were impacted by it the most, those in the community, we met with them. We wanted those from academia to be at the table, we met with them. We met with the folks who we thought, or who are the champions of the work, we met with them. And we also recognized that the policymakers, we met with them. And right now we are in a position to where that we might be able to get a small fraction. And when I say small, I mean really small fraction of the funds to do this work right here. It's an ongoing effort. We recognize, as I said before, that we're not going to let this right here stop our mission. We got some great folks at the table, and I'm not going to start naming like all the champions that we got at the table, because I might leave somebody out, and all of them are critical in the mission that we're trying to accomplish. But hopefully within the next month or two, we will receive some more funding, some more resources, so that we can really kick this off the ground right here. Because as the data show, and like I said, we could have broke the data down by days of the week, what times we're seeing the most shootings. We could have broke it down what season we're seeing the most shootings. Like, for example, like we know that January and February are the months with some of the fewest shootings on record, right? But we know that come at the end of April, going into June, we also start seeing an increase. So are we going to have something on there? And that's what we're working towards. But that proposal and that thing that we're talking about is really a comprehensive approach to violence, meaning that we're going to be inside schools. We're going to be, MJ, what's that, my cue? We're going to be inside schools. We're trying to work with recreational centers, community centers. We're working with religious institutions. We're going to work with workforce development, mental health, the kids department. So we're trying to bring everybody to the table so that we can fund this right here the same way they fund 495 when 495 fell down, the great fall down. We need that kind of intestinal fortitude from our leaders to get this job done.
Thank you, Daryl. I want to leave it up to the group. We have planned a breakout session to dive deeper into this, and I hope that to have explore some of these nuances. One of the questions that Dr. Berkey asked in the chat was about a comprehensive plan to address prevention across the spectrum. And I know that Daryl's talked about a few different things on that spectrum. But I think this is an opportunity for us from our different disciplines. We've got folks from DSAM and the kids department and gambling and researchers from a number of different universities here, community organizations, to break out into smaller conversations and see how we can come together around this work. To Daryl's point, this is the work of everybody. Violence prevention really is the work of everyone. Education partners are here, public health partners are here. We've got clinicians on the call. We've got a number of different people. And I'd like to move into the breakout session unless anyone is really, really opposed to that. Dr. Rapp, are you okay with that transition? I'm gonna make her the bad guy.
Yeah.
Okay. All right, folks. I want to once again thank Daryl for his insightful exploration of the data and raising our awareness and challenging assumptions and bias. And it's always powerful to hear that information. We're going to break out into different breakout rooms. There'll be a CDAS kind of facilitator in each space. We're going to address a couple of questions or ask a couple of questions, anything in the data and Daryl's presentation, Gemini's presentation and Daryl's presentation that was surprising to you. And what did you learn today that may have implications for the work as you move forward? And I would also invite that question that Dr. Berkey posed. What are the implications for prevention? How are you looking at prevention across the spectrum? So if you'll give me one moment, I'll move everybody into those breakout rooms. Welcome back, everyone, or almost everyone. Welcome, welcome. Some folks, the conversation's too good. They're not coming back. It's too good.
Well, we didn't even get through.
Welcome, welcome, welcome. Chambers, anyone that was in your group, I knew it was gonna be like, you need like a whole podcast, you know what I mean? Like a whole thing on the side.
Yeah, I was just study talking. Talk. Bumping my gums, as they say on the streets.
No comment, sir. No comment. No comment. Welcome back, everyone. Welcome back. Welcome back. Good to see everyone again. I know the conversation was rich. I'm out here still maintaining the frame on the Zoom, but I know the conversations were rich. I'm looking forward to hearing, from the different groups. And thank you. I'm glad that it went well. I'm glad that it worked out for everyone. I want to ask, in about a minute or so, to talk about some of the key takeaways in each group. Rachel, for breakout group one, Rachel Writing. Sorry, I know we've got a couple. What are some key takeaways from the group that you were working with?
Yeah, so we had a great group and really great discussion. Some of the things folks talked about being surprised about was the ages that Daryl talked about in terms of when violence was most prevalent. And we also talked a bit about that framing of being funded to fail versus funded to succeed, and really the importance in investing in these long-term structural solutions and not just sending a new person in every year or two with whatever grant we have, but really getting in the community and investing that and giving people those opportunities. And we ended, Daryl brought up this point about the importance of hope, and that we really need to bring hope, because when you have hope, it gives you that opportunity to know that tomorrow might be better, and that maybe there are different choices and opportunities to be made. And that's something that we really need to keep at the forefront when thinking about this work, is that we need to be bringing and investing in hope.
That's it. That's the slogan for the whole meeting, right? We don't need to go anywhere else. Thank you for that. Thank you for sharing that. Dr. Rapp, breakout room 2.
Yeah, so we had a really wonderful discussion. So thank you to my breakout partners. We did talk about a couple of the same things that breakout room 1 also talked about. We had a discussion around the question that Daryl asked about the age breakdown and why so many people in our group thought it was the younger as opposed to the older ages. We also talked about, that there is a lot of funding, and listed out some of the available funding sources. It's the allocation that may need to be changed or should be changed in order to support the necessary programs, and the importance of doing things upstream, which I think also leads to the prevention work that so much of us are doing. And another thing we mentioned is geography. There were some of us on the group who were from Philly, Sussex, Fair, and how we didn't know a lot of the information that was presented, that Daryl presented on today. So it was a great educational opportunity, but also contrasting and comparing with some of the experiences that we've had coming from other geographic areas, and that there may be opportunity to collaborate across different geographic areas since we're all working towards the same goal. So those are some of the highlights.
Thank you for that. I think that's so, important is, many of you know, I'm originally from Newark, and a lot of these same structural inequities show up in different cities. And if we only ever work on the Band-Aid fixes, we continue to have these inequities across cities and these outcomes that we know are connected.
The way you talk about New Jersey, sometimes I feel like it's so rainbow and flowers that maybe there are no structural inequalities in New Jersey, with sometimes how lovingly you talk about your home state. So
listen, you don't want violence, you got to go to the shore or something like that. I don't know, but but in Newark, we have challenges. It's a great place, lots of culture, lots of history, a lot of movers and shakers in Newark, but we do have struggles related to a lot of structural inequity, a lot of changes that happened over time in terms of movement of funding and moving of people and this mass exodus from the city, which took resources. So I have no qualms about my city. I love it, but I have no issues with that. Breakout room 3, Dr. Brittingham.
Good morning, everybody. So our room also discussed some of the same topics as breakout rooms 1 and 2. The big kind of takeaway and surprise with the first prompt was, in fact, the age range. Again, we all kind of thought that it would have been younger, but it was also discussed that, in fact, some other behaviors such as gambling, you see a increase as well in the 26 to 35-year-old, sort of the young adult age range as well. And then also, geography came into it as well, but also the discussion surrounding taking what's going on in groups geographically in different areas and saying like, hey, this works. Is it possible to do here? As well as getting the correct stakeholders at the table, or even having conversations with the stakeholders that are already there, because there's a finite number of resources. And when there are 8 organizations going after money for housing, it's like, is there a way to do this in a more meaningful fashion? Because now we're all fighting over the same funding, but could we come together and put together like a stronger proposal or something like that? But I will turn it over to you in the interest of time so that the other groups can also.
No, I think that's a powerful conclusion. I mean, if the goal is to get people into houses or get people into employment, oftentimes we're caught up in the infighting because there aren't enough resources and get distracted from the actual work of putting people in houses and making a change on the ground. And Daryl will tell us that's on purpose, but that's a whole nother Zoom. So thank you for that. Breakout room 4, Dana.
Yeah, we talked a lot about how the data was really interesting, and we would like to see it broken down more. I wish there had been more time to really delve into it. We had a couple of data people there in our room. So that was kind of the primary thing, but we did talk about, the WellBeing Index came up quite a bit, how that was a really interesting data point, but looking at that across different age groups or different populations, how that would be really interesting. The geographic, the structural inequity piece was really interesting. We wish you could have seen a little bit more about that. Again, it was these are little presentations, but I think what our group was saying was that it was very interesting, and there's so much more to explore there, and so many things that we could, so many ways we could look at the data to explore this topic more fully. I don't know. Daryl, Deb wanna.
Daryl, your email address is at the end of your presentation. If folks had questions or wanted to dive into that shooting data a little bit more, look at some more cross sections, could they reach out to you?
Yes, I'm always willing to share the data. I will actually, currently I got it in, I think, Stata in SPS format, and I'll send you the whole database. Like, you don't got to write nobody, just ask me for it and I'll give it to you. And as I update it, I'll just keep sending it to you if you want it.
Careful what you ask for, folks. No, I'm just kidding. Daryl's very knowledgeable about that. WISCARS does some interesting cross sections as well in terms of the relationship between the person who died and the person who committed the act of violence, or what was the relationship between the two people, parent and child, were they intimate partners, the mechanism of violence. And so there's a lot to dive into that. Breakout room 5, I believe that's Jim. Was there a key takeaway from that? Your group?
Yeah, and we talked about how knowledgeable Daryl was and the subject matter, but we also really talked about the need of funding to get people out, provide a livable wage and insurance, and to be able to have these programs fully employed and funded so people can donate time to address these issues, and that this balancing act and delay of trying to work a full-time job and do all the balances of life, while also trying to volunteer in the community and work out into the community, and how so many families have so much on their plate that it's so hard for them to carve out time when they're struggling. So this need to increase that quality of life so people can be more invested into their communities. We also discussed about some of the connections between poverty and violence, what some of the literature and theorists say are the mediating variables of why violence is shown to exist in high poverty areas.
All right, fun. Breakout room brought the science. I love it. I love it. Our final breakout room, Sharon's gonna share those key takeaways. She's also gonna lead us into the network share out and the close. So thank you so much, everyone, for your thoughts and your attention and your energy in this conversation. Sharon?
Thanks, MJ. A lot of the things that have already been said were things that we touched on in our group, but we did go into 2 different little streams of conversation that I thought were very important. One, we were fortunate to have some of the epidemiologists from DPH in our room, and they talked about the fact that they deal with the National Violent Death Reporting data, and how they would like to connect with Daryl to talk more, because he was so good at not only presenting data, but also visualizing the data with the mapping and also talking about the personal side of it, that they would like to work with you, Daryl. So I'm going to connect them later with you as well. We also had Erin in the group from Trauma Matters Delaware. I'm also affiliated with Trauma Matters Delaware. And we had Esther from LACC. And we ended up spending a fair amount of time talking about primary, secondary, and vicarious trauma and resilience, because the data resonated so much with Esther and the work that they do at LACC, as well as we know everybody who's working, in the community. This is not an abstract thing. This is a reality. You're working with clients who are exposed to trauma. You're working in areas where the trauma, the gun violence may occur, and other traumas and that sort of thing. And it led us to a question about our ability to be resilient in the face of that. And we talked a little bit about that and the need to self-care. And it led us to a discussion about some of the activity that Trauma Matters Delaware is undertaking in collaboration with Delaware becoming a trauma-informed state. So we wanted to mention that there is a work group specifically dedicated to primary, secondary, and vicarious trauma, particularly geared for the work that we do in prevention, first responding, healthcare, so on and so forth. And Erin's popping information in the chat with her email address. So if you're interested in learning more, you can definitely reach out to her about that, or certainly reach out to me. I think I captured the differences of what we talked about there. So now I'm going to turn it over in the last little section that we've got. I would like to just ask all of our members, first of all, thank you all for being here. We know how busy everyone is. This has been a really great discussion this morning. It's been very robust and lots of different perspectives. What we'd like to do now is turn it over for you all to tell us what's happening in your organizations, or from your little vantage point in the world, to tell us what your activities might be, any announcements you want to make, things of that nature. So I'm going to turn it over to all of you now to share.
Sharon, I'd like to invite Dr. Angelette to go first.
Thanks, MJ, and thanks, Sharon. I am working with the Delaware Racial Justice Collaborative, which is a group of about 200 organizations across the state that's really dedicated to eliminating systemic racism in our state and to put in place policies and practices that really promote equitable outcomes for all. And that certainly has been a part of our conversation today, is improving, having equitable outcomes for all. To that end, we are working with the Division of Public Health and a group called Green River to launch what we're calling a Equity Counts Data Center, which will be a central repository on the My Healthy Communities platform, where people from the community can go in and really look at key indicators around education, wealth creation, health equity, criminal justice, and the like, and really get profiles of what's happening in their communities, in their cities, their towns, their census tracts. This is it'll be an opportunity to really take a look at how we can improve. We'll have the data to be able to inform where are the gaps and what are the key areas that we really need to take a deep dive on to improve the opportunity for equitable outcomes among our kids, our families, our residents across the state. If anybody's interested in learning more, be happy to, talk with you offline.
Would you be able to put your email in the chat?
I will do that.
Great, thank you. Thank you for that update. That sounds really exciting. I don't see any hands up. You can just join. Whatever works for you all. I know you're.
This is Mandy Bundick from the National Violent Death Reporting System for Delaware. I'm an Epi, and I was messaging with Caroline, who is my principal investigator, and we wanted to let everybody know that as Gwen was talking about My Healthy Community, that our suicide story map for Delaware is going to be added soon. And we're not quite sure when. It's kind of in the, it goes in the pipeline, but that is a really large resource for anybody who needs some suicide or homicide data. We do have some violent death data on there, as well as overdose data. And we are working on updating that. With COVID and everything, some stuff kind of got, pushed a little bit to the back burner, but we're working on getting things updated as we speak. And I will put my email in the chat if anybody is interested in NVDRS data. We can talk about doing data requests, and we do have 3 years complete of circumstance data, and we collect 665 different data points. So we do have that available for homicides, suicides, and undetermined deaths that where the incident occurred in Delaware. So the death doesn't necessarily occur here, but the incident does. And we also have that data available for overdoses from 2018 through 2020. So I'll put my information in there, and if anybody needs anything, let me know.
We'd like to help you promote that data once it's available too. So please reach out specifically, Amanda.
I will.
Thank you.
Good morning. My name is Hanifa Shabazz, and I am working with the Wilmington Community Advisory Council as an advisor, along with Dr. Smith and Gwen Aguilette. And my major focus at this time is to get the necessary funding that is essential to what Daryl was referencing, the Community Violence Prevention Initiative. We are using the theory of the three-prong of having the hospital and the police enforcement and a community initiative being a foundation to address this violence, but getting it funded equally and equitably and efficiently is one of my passions. I believe strongly in this initiative. I believe strongly in the work, the grassroots work that Daryl and many of our Women in Community Advisory Council partners are doing. Because as in anything in life, you nurture and you feed the roots, and you deal with the root causes of what's causing an illness and effect. And we have all the data. We've been doing this for almost 7 years now. We have tons and tons of data, and we pick at it, but we have to get the necessary resources to really address it. came up with a practice that we kind of say universal. We give all of our children a vitamin when the epidemic was declared in here in the city of Wilmington. We give our children all children a vitamin, but then we have our selected children who need a vitamin and an aspirin and a vitamin. But then we have our selected who need an antibiotic. Coupled with COVID, our young children are in a crisis, and we're all in a crisis. We're all suffering some form of trauma. And so addressing the root causes of it requires funding and supporting the grassroots organization who is actually touching the lives of the individuals, who has the trust of the individuals. And then it's for us as leaders to make the necessary changes, because in the CDC report, it did say that we have public policy that is detrimental to the well-being of our young people. So I'm glad that everyone is hearing from Daryl, who is much more articulate in presenting this information to you than I am. But my passion is to get the support that's necessary to bring this to fruition and to stop the bleeding. As I said, I'm coming up on an anniversary of my grandson who passed on the 29th of January of last year. So I'm very emotional in it. And with that emotion, I'm working diligently to turn it into passion so that no one else feels the pain that my family's feeling. Thank you.
Thank you so much for sharing that. And our thoughts are with you at this time. I'm sure it's a very difficult time, but thank you also for channeling your efforts into the positive forward movement that you always have. We are just at time, but we do have a few minutes for others who want to stay on and share. We just always want to be respectful of our time frame for those that need to leave. If anyone else would like to share out, we're so happy to hear your voices and hear what you're all about these days.
Aaron, it's Bill Lynch. We just wanted to mention that the Attack Addiction 5K is on March 5th, 2022. But in our breakout session, I'm curious to Daryl's input on this as well. Being involved with the Camden County Addiction Awareness Task Force and also the Virginia Working Group and everything, much of this is also drug related. And what I'm curious is about Daryl having information with the shootings and the homicides, those kinds of things, and do you have actually overlapping data with regards to drug buys, deals, those kind of things. And the reason I'm saying that is because having been involved in the Camden County Addiction Awareness Task Force in New Jersey since its inception, we know that that was part of the problem, up to including the medical silo and the law enforcement silo and the community silo is so close together now there that we had issues where we had significant overdoses occurring, more than 10 overdoses brought into Cooper Medical Center in the city of Camden in less than an hour. They notified the New Jersey ROC, they notified Camden County Metro Police and the prosecutor's office, undercover buys go out, and this was shut down in 3 hours, up to including the individual who was selling the fentanyl-laced heroin was arrested with 49 more bundles on his person with regards to his intent to distribute that through the neighborhoods. So the reason I'm asking is I don't know if Daryl has that information. I'm curious about Daryl's input and how much he thinks that is also a contributing factor. I know it's multifactorial and multimodal, but we know that that's been a major issue with that. And everyone kind of rallying around that particular issue has brought the community, law enforcement, and even medical together. We were operating in silos. That's not the case anymore for sure. And that's been very beneficial in helping make Camden and the whole county a safer place.
Yeah, I wouldn't see Delaware is really small. And the one thing I learned from our breakout session is that there was like 1 to 2 degrees separation. Like all of us was connected somehow, some way. So the unique thing about Wilmington to me is that we're really closely connected. So I know people always talk about working in silos or not in silos. And I got this new saying that we measure change differently. And I think maybe about 3 years ago, you would have had a police department who kept all their data internally, didn't share it with nobody. It was all about them getting the accolades. Like it or not, you can say what you want about Chief Tracy. He's a well-read man, meaning that he actually understands the phenomenon of gun violence. And he knows that in order to do this correctly, as I mentioned before, you got to have one-way conversations, but you also need to have the people in the community involved in it, taking some responsibility. You got to have the court system taking some responsibility, and law enforcement and the likes. But the one thing I would say is this, is that there's also a degree of caution involved too when you talk about some of the work that you do. Working with the hospitals, I know that because of HIPAA laws, it's really hard for them to really like give us a lot of information that we need. And it's also the same caution with them work with the police department. A lot of my guys who are formerly incarcerated guys and gals, we still don't have that relationship with the police department in our community, to where that we are out there with them doing that kind of work right there. But we are working, and we have made progress, and at least recognizing that it's going to take all of us to address the effort. The one thing I will say is that we have been out there trying to address the opioid, the overdoses and stuff. And I have to go back to what Jim said. I don't know if the homelessness came first, then the mental health, then the drug use, or the drug use, or a combination thereof. So really, Dr. Lynch, that I'll be like interested to talk to you, so that you and I can go through and systematically go through a lot of this data to see where we at with it. Because it's something that's been puzzling me for a while. But I do know that we are seeing on the streets a lot more fentanyl laced pills. So we're seeing a lot of counterfeit pills. So the Percocets now are definitely fentanyl laced. The marijuana's fentanyl laced. The ecstasy pills got fentanyl. So there's a lot of stuff there. But it's really hard to get that kind of data, especially if it's self-disclosed data, to where that on a survey you're asking somebody, do you, especially young folks, do you pop perks or do you pop ecstasy? Because it's not something, it's still a stigma attached to it. So Bobby, willing to talk to you about it in more in depth, Mr. Lynch.
Thank you. Anyone else want to make an announcement or ask a question?
Daryl, I just sent you my email and directly to you in the chat, so you have it. Thank you.
Okay. All right. Well, MJ, I'm going to turn it over to you to close us out.
Sharon, I think you were supposed to close us out with a song or maybe virtual hand holding, not in-person hand holding, Jones, but
I can do the old Carol Burnett. I'm so glad we had this time together, and I have done that. So
I just want to thank everyone for taking time to talk about what can be a challenging topic, what can be an emotional topic, and that this is, bringing the data alive and really doing the work at all levels, community levels, state levels, advocacy, data science. I want to thank everyone for their efforts with this, and to bring us home. Prevention is prevention, right? And so I want to honor the work you're doing in different spaces, whether that's substance use or violence prevention, and how much overlap there is. So thank you for that. We'll make the recording available as well as the slides. And have a great day, everyone. Be well. Take care of yourself.
Thank you.
Thank you, MJ.
Thank
You
you.
go ahead.
Thank you.
Bye.
Thank you.
Bye-bye.